Hi everyone, welcome and good evening to the first virtual journal club organised by the British Society of Interventional Radiology, Trainees Committee and IR Juniors. Thank you so much for giving up your evening to join us. I hope you're all as excited as me and the rest of the panelists. So this is the first session of this new initiative, which is really designed to encourage junior trainees and medical students to partake in research discussions, showcase all the amazing work that is happening in the IR research world, and also hopefully to encourage some networking between different countries. As you will have seen, we have many institutions across many countries and continents represented this evening. So definitely fire any questions in the chat function as they come to you. And because it is obviously our first session, we do want all your feedback for this event and subsequent events, and we will be posting the feedback link in the chat as well. And some of the references and papers that we may be talking about during our discussions, we will also post in the chat function. So keep an eye on that. So without further ado, I just want to introduce my co-chairs. I've just realized I haven't actually introduced myself. My name's Jim. I'm an IR trainee in Leeds in the United Kingdom. I have the honor and privilege of working with the BSIRT this year, and I'd like to introduce Indra and Rosemary. So if you guys could introduce yourselves, and then we can get the panelists introduced.
Oh, so hi,
hi everyone.
Sorry.
Oh, sorry.
Go ahead, Rosemary.
Thank you. So my name's Rosemary. I'm currently in my final year of study at the Hull York Medical School in the UK. So I'm also the BSIRT medical student representative, and I'm part of the IR Juniors core team.
Well, so hi all, my name's Indra. I'm currently an FY2 doctor, so second year out of medical school in the Oxford Deanery in the UK. I'm also part of the IR Juniors core committee as well. So really happy to announce this collaboration, and hopefully you enjoy the session. And then we'll hand over to our panelists to introduce themselves.
We have some amazing panelists today, and they're really going to showcase how diverse interventional radiology is. And thanks so much to all the panelists for joining in, and really look forward to discussion. So if we just go in order, Madhu, can you go first?
Hi everyone, my name's Madhu. I'm an ST3 radiology registrar in Oxford Deanery in the UK. I'll be presenting the paper today. Thanks, Jim.
And Elin?
Hi, my name's Elin. I'm an assistant professor at Daughter Institute in the USA.
Thank you. Neil? Oh, you're muted, Neil.
Basic step one. My name is Neil Gupta. I'm an IR consultant in UHW, University Hospital Coventry. I did my training at Imperial College, and then I came up to West Midlands to do my foundation training and straight into radiology. Did 5 years of training, and then I went to Australia for a couple of IR fellowships, and I came back as a consultant. I am a college tutor for clinical radiology. I'm the interventional radiology training lead for the West Midlands, and I also sit on the BSIR membership and rules committee. And my IR interests are very broad. I do everything. IO, vascular, non-vascular, anything that comes the way, I'll do.
So we'll be asking Neil lots of questions tonight and tapping into that multiple training experiences. Apurva?
Yeah. Good evening, everyone. My name is Apurva. I have recently graduated from medical school in India, and I've moved to Rochester, Minnesota, where I'm pursuing my research fellowship at the Mayo Clinic.
Thank you. Vicky, thanks for joining us.
Hiya, just in time.
Vicky, do you want to just tell us about, where you are and, where you've been working and your training experiences?
Yeah, sure. So I went to uni in Bristol and then did my foundation training in Somerset before going straight into radiology. Started radiology training in the West Midlands with Neil, and did about 3 and a bit years there, had some time out for maternity leave, then went to Canada for a year while my husband was on a fellowship, and then came back, had some more maternity leave, and then moved up to Sheffield, where I've been since then, working at 80% less than full-time as a trainee, and I'm now an ST6 in IR.
And you've co-authored this paper that we're presenting. So
yes.
thank you. Fantastic. And Ornella?
Hi guys, my name is Ornella. I come from Greece. I'm a 4th year radiology resident. Here we have a general radiology, and in our general radiology we have 6 months of interventional radiology that I've done already. And another 2 months I've done in Switzerland, in Zurich, of extra practice.
Thank you. And Tom?
Hi everyone, my name is Tom Gordon. I'm currently an IR fellow at Guy's and St Thomas's hospitals in London. Before that, I was doing radiology and IR training in the southeast of Scotland deanery, which is predominantly based in Edinburgh.
Fantastic. And last but definitely not least, Rajat Chand. Thank you for joining us all the way from Michigan.
Of course, thanks for having me, Jim. Nice to meet you all. My name is Rajat. I'm a PGY6 IR resident at Beaumont Health in Royal Oak, Michigan. It's nice to be here.
Thank you. So those are our panelists, and first thing we're going to do is hear from Madhu, who's going to present our paper of the month about IR training, and then straight after that into discussion. So Madhu, you can share your screen at this point. Thank you very much.
Thanks, Jim. Okay, can you guys see my screen?
Yes.
Okay, brilliant. So I'm going to present this paper. Let me just get rid of the Zoom box. I hope that's got rid of that. So yes, like Jim said, I'm going to present this paper on global perspectives on IR training, which was published in CBR a couple of months ago. I'm going to go through the methods and the results first of all, and then follow this up with a brief critical appraisal of the paper as well. So first of all, let's start with how this study was done. So the aim of this study was to understand the current state of IR training across the world and to measure trainee satisfaction. This was fulfilled using a questionnaire, which was designed by the BSIR Trainee Committee, and this was circulated using SurveyMonkey as a platform. As you can see, there are some example questions here on the right. The questions were then circulated via an anonymous single-use web link to members of various IR societies, and this was done between November 2019 to March 2020. This is the study flow diagram, which shows that of all of the people who clicked on the survey link, 608 were eligible. This includes 3 groups of people, so IR trainees, radiology trainees either prior to starting IR or who are not doing IR at all, and also junior IR consultants within 2 years of qualification. The second half of this flowchart is on the next slide. So as you can see here, of all of the eligible people, 496 completed the survey. The survey itself was in 2 parts. So the first half was a more generic survey that was for everyone. And then the second half was more specific to IR training itself. And that was only for people who were doing IR as registrars or as junior consultants. Some people did drop out after doing the first half of the survey. So these are the demographics of the people who completed the survey. 2/3 were male and 1/3 were female. About half of all the responders were from the UK and EU. And as you'll see later on through the results, the authors analysed the results of this paper by these 4 regions, so UK, EU, USA and Middle East. So the first set of results are to do with exposure to IR and how it affects career choice. This figure is taken from the paper. So we start on the top left-hand corner. The vast majority of responders said that their first exposure to IR was either before radiology training, which is the green bar, or in the first year of their training, the dark blue bar. On the top right, you can see that most responders had more than 4 weeks of IR experience within the first 2 years of their radiology training, and that's the yellow bar. On the bottom left, 80% of responders either agreed or strongly agreed that early exposure to IR really impacted on their career choice, and these are the green and dark blue bars. The next set of results are to do with trainee satisfaction, and this figure is also from the paper. On the top left, we have overall satisfaction, and you can see that overall satisfaction with IR training is high across all regions. These are the yellow and pale blue bars. On the top right, we have the fact that the majority of IR trainees across all of the regions of the world would recommend their specialty to other colleagues or to juniors. Interestingly, the authors looked at the data within these top two graphs and did a separate subgroup analysis by gender. And they found very similar results in women, with nearly 70% of women being satisfied with IR training and 90% recommending IR as a specialty to others. On the bottom left, there's a question about work-life balance. Work-life balance was reported as being good most weeks or good every week by 2/3 of the participants in the UK. These are the orange and the pale blue bars. In contrast, this was slightly less good in the rest of the world. About 1/3 of participants in the rest of the world said the same about work-life balance. The authors went on to explore satisfaction with various different aspects of IR training, divided up by subspecialty. And I've just created this figure for this talk just to summarize some of their results. So let's start on the left with vascular work. UK participants, shown in blue here, have a greater degree of satisfaction with vascular work as compared to the other parts of the world. And this is significantly greater for peripheral arterial disease than it is for aortic work. With urology training, UK, USA, and Middle East participants were satisfied with a slightly less level of satisfaction seen in EU trainees. And finally, with hepatobiliary, interventional oncology, and CT-guided ablation, a different pattern emerges. And you can see that USA participants have a much greater degree of satisfaction as compared to the rest of the world. Now, the authors wondered whether this reflects the fact that in the USA, the majority of endovascular work is undertaken by vascular surgery. And as a consequence, IRs are freed up to do more non-vascular work. And the authors did ask a follow-up question to try and follow up on this theme. And this did show that 61% of trainees in the UK felt that their training was negatively compromised by the presence of vascular surgeons, whereas this was a small minority in the USA, possibly because there's less direct competition there. The survey then went on to identify some further areas for improvement in training. So starting with a dedicated IR on call, for which it appears that there was very patchy provision globally. A second area that they identified was exposure to research, with most people having exposure either via case reports or quality improvement rather than original research. The authors also went on to look at participants' intentions after training, and they found that approximately half intend to apply for a consultant post straight away, whilst a third intend to gain a bit more experience via a fellowship before that. And half of all participants wanted to sit the EBIR exam, and this was mostly UK, EU, and Middle Eastern trainees. So now that we've run through the methods and the results of this paper, I'm going to evaluate the paper briefly using these 6 different aspects of questionnaire research as laid out by this paper by Boynton and Greenhouse. So let's start with study design. The design of the study was entirely appropriate, using a questionnaire to answer the question, which was understanding the state of IR training. Next, we move on to validity and reliability. So for a questionnaire to be valid, we need to show that it truly measures what it sets out to measure. And for a questionnaire to be reliable, we need to know that it provides stable responses over time. Unfortunately, there's no validated questionnaire out there in the literature to do with this exact topic that the study could have used. But one possible way to have validated the study would have been to run a pilot questionnaire, and this would check that the questions are indeed assessing what they intend to. Another possible suggestion is to improve reliability by repeating a previously done survey. So for example, the authors could have used the BSIRT IR Trainee Satisfaction survey from 2016. And this would allow a comparison of responses over time. But this has its own limitations because the previous survey was UK only and covered a much smaller range of topics. The format of the questionnaire itself can lead to bias. The questionnaire was in English only, and it did use very UK-centric terminology such as foundation training and taster week, and these are less applicable to non-UK responders. A strength of the questionnaire was that it was anonymized and it was self-administered, and this does reduce the risk of people wanting to give socially desirable answers. There is, however, a risk of response bias as a result of the way that the questions were phrased. So as an example, take a look at this question. Responders may have been biased to agree with the question that their training is compromised, and the question could well have been rephrased a bit less suggestively. So for example, how does the presence of vascular surgeons affect your IR training? And finally, another thing to say here is that this was a relatively long survey, and the authors did acknowledge that that may have affected the thoughtfulness of the answers. The sampling included the members of various IR societies across the world, as well as one general radiology society, and that's the RCR in the UK. It is possible that IRs who were not society members were excluded as a result of this. The study used a single-use web link, and this was to prevent the risk of duplicate answers, and being anonymized, the risk of response bias was also reduced. It is possible that responders were part of more than one society. So for example, in the UK, it's very common for IRs to be members of the RCR, BSIR, and CERSI. And so duplicated answers could theoretically have been possible if someone really fancied doing the questionnaire again and again. The response rate to the survey was very clearly reported in the study flowchart, which I showed you earlier. There are clear differences across the globe, and in particular, there were a few responses from places like Australia, Asia, South America, and Africa. These regions were underrepresented in this survey and were excluded from the subgroup analyses by region. The study also clearly reported a dropout rate, which was fairly significant and presumably due to the length of the survey. All of these factors could have resulted in a degree of selection bias, with systematic differences arising between those who decide to cooperate and complete the whole survey and those who don't. And finally, the study carried out a very clear analysis of the results by region with lots of nice graphs, as the examples I showed you. A possible suggestion would have been to have analysed whether these differences between regions were statistically significant and to perhaps include confidence intervals on the graphs, but this may well have been tricky due to the small numbers per region by the time you've divided all the responders up. So after all of that appraisal, here's my bottom line. The methods and results were very clearly reported, and these are our best available data. The paper has identified some very interesting points. So first of all, overall, most IRs are really satisfied with their training and their specialty choice. Secondly, exposure to IR early on is absolutely crucial for recruitment. And thirdly, this highlighted some issues with training and some areas that could be improved in the future, such as dedicated IR on calls, training in different subspecialties within IR, collaborative working with other specialties, as well as research. So thank you very much for your attention. I'm going to unshare my screen and happy to take any questions at the end.
Thank you so much, Madhu. Fantastic presentation. You've outlined all the results. Thank you for doing that for us, Madhu. Really well done. Any questions from the audience at all that you can see there, Rosemary, that we should ask Madhu?
There are no questions. So if anyone has any just feel free to pop it in.
Get any questions in, we'll keep an eye on the chat function. I mean, as Madhu's already highlighted from the survey, there are clear positives from global IR training. I think it would be really interesting to hear from the experiences of their own training from each of our panelists. Perhaps we can start with Team USA, very high levels of satisfaction all round. So what's the secret? Shall we start with you, Elin?
Sorry, Jim.
Oh, go on.
Sorry to interrupt. We've just had a question come through.
Okay.
So it's actually a UK-based question. So my training scheme divides IR into vascular and non-vascular, but some radiologists such as Neil seem to do all aspects of IR. How prevalent is the vascular non-vascular split? And how does one reconcile a training scheme that divides IR into vascular and non-vascular with a desire to be a consultant doing all aspects of IR?
Thank you. Neil, you've been name dropped, and obviously you do everything. Could you possibly, with your IR TPD hat on, give us an answer to that?
Yeah, that's a really great but impossible question. It very much depends on the region that you train in, I guess. So, for example, I said I do everything, but if you think of something like GI stenting, that's not something that we do at any hospital in the West Midlands, and there are 6 sites in across the West Midlands that do IR, but none of them do GI stenting. So, for example, that isn't trained in our region, but I know there are centres around the country that do that. And similarly, things like vertebroplasty, again, is quite patchy, the delivery of that. And I guess the problem will come is the vast majority of trainees who train in a region actually end up staying in the same region that they've trained. So that issue doesn't become an issue because you've trained with the people you end up working with and you've trained in the procedures that are offered in those regions. The problem comes is if you want to travel out to another area, in which case you may not have trained in the specific procedure that is then offered at that centre. And then you end up having to learn that from scratch in the new centre. So I'm not sure how to answer that any better than the fact that it's very specific to the region that you train, and you model yourself on the individuals that train you.
So I did have a follow-up to that, actually. So do you think there's an argument for trainees to rotate around loads of hospitals just to make sure they get everything, or
yeah, so as I said, we've got 6 hospitals in our region that do IR, and as you say, they're all slightly different in regard to what they offer more or less of. So, for example, some institutions will be very heavily vascular and not have a great deal of HPB or urology, whereas others will have maybe more IO and less of the vascular. So when I look at the training of my individual trainees, I make sure that they rotate through sites that will offer them the entire broad breadth of specialties. So they can basically concentrate whilst they're at like Worcester, for example, has a huge amount of vascular. So when they're there, they do their vascular kind of focus. And then when they go somewhere else, for example, Coventry, they'll look at something like ablation or IO embolizations, things like that. So yeah, I think that, but the difficulty with trying to travel between deaneries will be very, very difficult, not only financially, but also just logistically for trainees. So I think, unfortunately, you end up having to stay within your region, but trying to make sure that you cover the syllabus throughout your 3 years across in the region that can offer you it all. So definitely rotating, but I don't think it's realistic to expect trainees to go outside of deaneries.
I think that's, yeah. Go on, Greg.
Can you hear me?
Yeah.
So I completely agree with Nick. Oh, hi, by the way, I'm Greg. I'm one of the interventional consultants from Guy's and Tommy's. I think these are all very valid points, and I think that it's important to be able to rotate between DTHs and tertiary centers, and it's also important to. I mean, that's probably one of the little problems with radiology training in the UK, that very often it's a run-through program. You do your clinical radiology in the same center, then you do your fellowship probably in the same center, and you don't see much else. But as long as your training is general. So for example, okay, let's say you don't do much interventional oncology, but you do trauma and you do hepatic artery or DDA embolization. So these are skills that you learn and they can be transferable. So if you go to a center that does more IO, then you can transfer those skills. And obviously, then it's up to the team that you're joining to help you and train you and bring you up to this. But I think that as long as you have the experience and you have you have done enough cases from certain things, then you should be able to cover most things. And let's not forget that the RCR has certain things that under the curriculum that we should be able to do. And I completely agree that very often these things are a bit unrealistic. So if you look at the RCR curriculum now, it says that all the IR fellows should be able to do a complex EVAR by the end of their training. And we know that this is not true. I mean, very few people can do that. But I'm sure that most IR trainees should have done infrarenal EVAs, for example. They should be able to do one, maybe not independently, but they should be able to do one with the help of a consultant. And I think that the same thing applies for most of the other procedures, either they are an embolization or vascular. And I think we should keep it like this. We should keep our training as general as possible without dropping procedures.
Vicky, you've got your hand up.
Yeah, just similar, just to echo what the others have said, really, and having spent time in 2 different deaneries because I transferred, it is very, very different between different deaneries. But I think you have to seek out at an early stage what is good in your deanery and try and pursue that. And if it's something that you really want to do that isn't in your deanery, then be looking at it from an early stage of where you might be able to spend a 6th year or potentially a 7th year of training, if that's an area that you really, really wanted to, to specialise in. I think, within the curriculum, within training, there is the line that sort of says, if the specialty that you want isn't offered in your area, then, you can be supported to work in another deanery. And I think that does stand for IR if it's something that you really desperately wanted to do in your 6th year that you hadn't been exposed to somewhere else. For example, paediatrics, I think that's quite hit and miss, but if you wanted extra experience in it, then there would be an option to go somewhere else.
Yeah, thank you.
I just had one. Oh, sorry, go ahead.
No, you can go ahead. I can cover it later from the United States perspective.
To get a US perspective.
Yeah. I was about to talk about the US perspective as well. I believe you should go first. You're attending, and I can go next. I'm a medical student.
Oh yeah, sure. So I agree with Greg. No matter where you go, no single institution will provide you all the experiences that you may need or will need to encounter in the future. As a teacher and an instructor, what I tell my trainee is that I will try my best to equip them with the skills necessary to apply to every single part of IR. So like Greg was saying, we'll teach you how to do a hepatic angiogram, and that will equip you with the technical skills of doing so. And some of the clinical aspects that may just happen a little bit later when you become an attending or a consultant. In the US, though, we do have the benefit that most academic institutions have multiple affiliate hospitals. So a typical way it looks like is a big academic center with, transplant centers, complex procedures, vascular, non-vascular, and that is commonly associated with a county, a local hospital that sees a lot of trauma, and is also associated with a veterans hospital that has a totally different patient population and therefore disease process. And the trainees really benefit from rotating through these different sites. So it helps to cover a greater number of cases or different types of cases, but it does not guarantee that they'll still get the full spectrum of experiences that maybe people get in Europe or in Japan or somewhere else. But they will have the skills necessary to build upon that later.
And I think we shouldn't forget that very often, many of the procedures that we have, we have standard today, like prostate artery embolization. This technique didn't exist 10 years ago. So the guys who are actually doing it now, they had to learn how to do it as they were going. So they had they had good principles. They knew how to do an embolization. They knew how to use microcatheters. And then, they developed their skills to do PAE. And I'm sure there are going to be more other, techniques like this that are going to develop in our lifetime. So I think as long as you have the core skills, the rest should come. And if you have good mentoring and good supervision, then it should be okay and safe for the patient.
I totally agree. I mean, I learned genicular on my own.
And regarding the table where you spoke about, on the paper where they spoke about the aortic and the peripheral arterial work, the US trainees don't get to do much. I would agree and disagree as well. Disagree in the sense I have rotated at 3 different institutions as a sub-internship for my final year rotations, like a final year medical school. And I've seen that all the fellows are posted for a month in vascular surgery, where they get to learn from the vascular endovascular surgeons to do the endovascular procedures. Do I believe the 1 month is enough? I don't believe it is enough. Having said that, when it comes to practice, I believe the vascular surgeons take it over. So not many not many institutions IR do the vascular work. So yeah, so that's what I would like to put forward. Yeah.
And I have to say that these questions were a bit provocative. And I mean, Vicky and I are 2 of the authors of this paper. And I have to say that Madhu did a great work to critique our paper, and I completely agree with all the points that she raised. We know that, I mean, and probably Rajat can say a few more things about this, about the vascular training in the US. We know that the Americans have put more emphasis into oncology now. In the UK, we're still holding up on this. We're still holding on the vascular practice. 1 month in vascular surgery is nothing, unfortunately. Of course, there are centers in the US that they're still doing loads and loads of vascular. There's no doubt about that. It's, of course, this questionnaire, this survey was from what we know, is that it was the first survey of its kind. It was the first survey that tried to see what's happening at the global level. And the main limitation, as Madhu mentioned, was that it was, despite our efforts, I mean, whether you believe it or not, this survey took 2 years to bring together. And it was so hard to get everybody to buy in, and to all the societies to help us to circulate, to reach as many people as we could. And unfortunately, despite the best efforts of our partners in the SIR RFS, it wasn't possible to reach. I mean, we only got, I think, 50 responses from the US, which is obviously is not enough. It's not enough to get a decent, sample. But at the same time, I think it gives us an idea. It gives us a taste of what's happening and of what maybe we should try to avoid in Europe and in the UK.
Yeah, and I'll just chime in there, Greg. Thanks for name dropping me. Now I have to say something. I just want to echo everything that everyone said. We are all a part of, biasly speaking, the greatest specialty in the world, right? We do everything from head to toe, and we're cutting edge, and it's so exciting. So when trainees see our specialty, they want to learn how to do all these cool procedures, and they want to be able to do all these, amazing things with, with all this great technology. But I think it's important to echo on what Yulin said, is that you really have to learn how to clinically manage these patients. And I think that's what the US has really put forth with a clinical model, because our patients and our other subspecialty providers that we work with aren't going to respect us unless we really know how to manage them clinically and follow them up clinically. So I think that's another really important part of the equation for trainees, and to keep in mind and to really hone in on. You want to go to a program that's going to teach you these skills that we all know and that we all agree are transferable. Once you get really good on the ground basis of IR and learn hands-on work and get good with certain skills, you can transfer them to other things. But if you're an attending or a consultant and you're trying to learn how to manage patients clinically, it's going to be tough if you didn't learn how to do that early on in your training. So I think you really want to go to a program that's going to be able to let you reinforce those clinical skills and really learn and be able to take ownership of patients. And so that once you do get into the real world and you are able to use all this amazing technology, that you're not afraid to really follow up your patients long-term, because that's what really matters at the end of the day. And that's what other specialties are going to respect us for and actually send us more patients for. So that's the only other thing that I would add.
I think there's definitely a drive in the UK to make IR a much more clinically focused specialty, and I think that's really important. Ornella, can I ask you what your experiences of your own training is like, and what the training structure in Greece is like for IR? Oh, you're muted at the moment, Ornella.
Hi, can you hear me now? Good.
Yeah. Thank you.
Okay, so IR in Greece is part of radiology. So you need to do 5 years of general radiology, and within these 5 years, you do 6 months is in your normal curriculum. And after that, you can either follow a fellowship or travel abroad or do a postgraduate or even do the EBIR exams, and then you can be an interventional radiologist. We also have all sorts, like we have interventional oncology, vascular and non-vascular. The difference is, as Rajat said, that we don't have one-day clinics, we don't have our own departments. So and I think this is also very important for younger colleagues to follow. They might be really scared of the clinical practice, because we don't really get taught, besides medical school and maybe foundation years. I think it's quite important to learn also some clinical training and to be able to treat patients from all parts of interventional radiology as well. I think that will help a lot. We don't do AVARs as well. That's as I saw from the graph before. In Greece, at least, we don't do AVARs. In Switzerland, they do, and they're really good. Yeah, so I think that's the general idea of what's happening in Greece.
Thank you. Tom, I'm conscious we haven't heard from yourself, and obviously you trained in two different centres with vastly different experiences. Can you share some of that with us as well?
Yeah, sure. So I did my diagnostic and IR training in Edinburgh initially, and I'm now currently doing an IR fellowship at Guy's and St Thomas's in London. To be honest, the kind of life as a IR trainee and fellow in both sites is pretty similar in terms of your IR sessions and your work from day to day. You're essentially during your IR dedicated sessions, you are in the room doing procedures. The main differences have really been the type of work that I've been exposed to. So I've touched on all these points here, but purely dependent on the hospital setup that I was training in Edinburgh, I got better, a lot of exposure to certain types of IR procedures. And the reason that I wanted to pursue a fellowship was the fact that I had an interest or knew there were these other things that I hadn't seen yet and liked the look of, and wanted to go on and further some of those skills elsewhere. So that's why I went after a fellowship. But some people don't do that in the UK. Not everyone goes on to do the kind of ST 7 year. And I think that has to be a decision for yourself as an individual, where you're going for your consultant job or whatever your next step is going to be. So yeah, two similar experiences. I think the good thing about moving between two different sites, I'm sure Vicky found the same thing when she went between two deaneries, is that just purely learning from different people and seeing different people work is really so important, and has been the most positive thing for me. And you really learn a lot just from working in a different department. So yeah, that's been a benefit.
Obviously, in the UK, there's a drive toward potentially also what the US have done with a dedicated IR training program, where from the first day of your radiology training, it's a IR focused training program. Obviously, with the integrated IR residency program now in the US, we probably have many lessons to learn. I wondered if Elin and Rajat could share some of their knowledge about the integrated IR residency program.
Yeah, sure. So I actually trained under the traditional program, but everyone who end up going for IR or even basic radiology, they always have a year of internship. The year of internship can vary individual to individual. In those now integrated IR residencies are typically surgical in nature. And it makes sense. We manage our patients very similarly to surgeons do. I actually did what they call a transitional year, where I did OB-GYN, medicine, and surgery. So I had a wide breadth of exposure as an intern and for clinical management of the different specialties. But then afterwards, what I did is I actually did a general diagnostic radiology residency because at the time, I actually wasn't sure whether IR is the right field for me. I completed that at UCSF, and I spent kind of the latter half of my residency really focusing on IR. I did end up going away for fellowship at Miami Vascular because it did offer a whole different set of cases, a whole different set of procedures. But also it's different is you learn that coast to coast in the United States, there's very different practice patterns. There's very different ways of tackling the same procedure, and there's very different ways of patient clinical management. And this is just different. And I'm sure the US is going to be different from Europe. And learning the different ways was very, very helpful for me. And since 2016, now there has the integrated program where they have a kind of residents, going from DR straight into the IR, kind of in the integrated system. There's also the independent IR residency. I think the last I heard, there's about 170 position open where medical students directly apply to it. And then there's the ESIR, where I'm sure where Raja can talk to more about. Basically, you do 3 years of DR and then go 1 year of IR. And one of your years in DR is going to be completely focused on IR. So that is more months than there's allowable typically in a regular DR residency. In terms of kind of the independent IR residency itself, it is 4 years of straight DR and 2 years of IR only kind of training. I actually think there is some value to that because these 2 years you'll be completely focused on IR, but you'll also become very good in DR because you're not an interventional radiologist until you're first a radiologist. You have to know what you're doing. You have to be able to understand what you're treating. Are the outside imaging correctly interpreted? And that is what sets us apart from surgeons and other fields.
Thank you. I've seen, I know Rajat probably has some comments. Neil, you've got your hand up though, so we must address your burning question.
Yeah, I just wanted to say, I think we've got a little bit of a problem in UK in the fact that because IR has stemmed from radiology, the people that have chosen radiology in the past have been a certain mindset who've wanted to maybe not be a frontline, not doing OBGI and not be doing, acute medicine and A&E. And then they've stumbled into IR because they've maybe thought, well, actually, I don't really want to be sitting in a dark room all the time. I do want some patient contact. But by inference of that, the IRs that some of the older IRs that we've got don't like the clinical aspect of it. They don't want to have the responsibility and the clinical ownership. And that is a problem because as Rajat was mentioning, that's what we do need in IR to be able to excel. And I think for years we've been fishing in the wrong pool of trying to get our people into IR from the diagnostic base. And you've been trying to convince people to come from who've chosen DR to come into the IR specialty. Whereas actually we need to look outside of that field and look at people that are potentially looking down the surgical pathway or other pathways to go, you know what, that's not the future, IR is the future. And to get them coming in straight into radiology with the intention of doing IR. And I think that's where people like me have started to come in, and the mindset is starting to change, where we realize you can't just do it as a technical thing because you're going to lose it. You have to take the clinical responsibility, which is what our American colleagues have done. So now having to change that mindset is quite difficult because you've still got the old guard where just want to do the procedure and send the patient back to the ward so that they don't have to worry about anything else. Whereas we have to, as everyone's saying, take that responsibility, and that is a big mindset change. And only as the it's not fair to say the older generation, because that's not fair at all, because there are some fantastic older people that still have this mentality. But I think generally, particularly at DGHs, we need to change that mindset, and it needs to come from the grassroots with guys like you, the trainees coming straight into radiology with the intention of doing IR, having the clinical acumen in the background, and that will take a huge amount of time. But we're, as Rajat was saying, we're kind of at the coattails of America, and we need to catch up.
Yeah, I think those are all great points, and I'll just echo on some things that Neil and Yolan have said. So basic training breakdown for IR is, as Yolan said, diagnostic radiology, traditional residency, 2 years independent residency following that in IR. So 2 residencies that you end up doing. One is in diagnostic radiology and the other is in interventional radiology. And that's called the independent residency. If you're an ESIR, you get 1 year of dedicated training in your diagnostic radiology training. So 3 years of diagnostic radiology, 1 year of ESIR, which is essentially all IR, plus some subspecialty clinical rotations like ICU, hepatobiliary, vascular surgery. And then you also have to do 1 extra year of independent IR residency. So you still have to do that extra year. But even if you do that extra year, it's determined by your program director whether or not you're finished at that point. If you're an ESIR and you've done the extra independent year, your program director gets to say, well, I don't think this guy is ready. Let's tack on the extra second independent residency, because the independent residency is 2 years. And then you have the integrated residency, which is the whole package, 6 years altogether, including internship. And radiology has traditionally been a very competitive specialty. And it makes sense that integrated IR residency, or even if you're approaching to do it the independent pathway, is also very competitive. So, we are really getting the best and brightest in the field in terms of medical students. But I'll tell you this, if you're just going in it for the glory of procedures and the technology or whatever it may be, you're going to learn the hard way. You're really going to learn the hard way with a new clinical model. If you don't like seeing patients, treating patients, interacting with patients, interacting with different subspecialties, you're not going to be happy. This is bottom line. And I've heard, it's only been very recent that the integrated residency has been established, but I've heard of people switching out. They're going to other, a few people here and there are getting out of the integrated pathway and they're going into other specialties. It's just a reality of the situation. So what I would say about this is, choose a program as a trainee that's going to allow you to get good clinical exposure. That's really what's most important, and that's what the clinical model emphasizes. Choose an internship that's going to get you good clinical exposure. Don't just do something that you want to get into to float by, because you're not going to be able to get those skills again. You're not going to get those learning opportunities again. And go to a radiology program. Even if you go to a diagnostic radiology program, full-fledged 4 years, you don't get any of that specialty IR training within your DR program. Choose a program that's clinical. Within your IR rotations, ask how clinical it is. Within your DR rotations, ask how clinical it is. The thing that sold me for my DR residency is when my program director told me, hey, listen, when you guys are down in the emergency room and you're reading scans, go and see the patient, go and examine the patient, go see them, do a physical exam, palpate that mass, test their pain, what is their pain level? Those are the things that really matter and are going to be carried on when you get into your actual, IR training, whatever that may be. So that's really all I would emphasize, is that, the skills and the technology and whatever not, that will come when you're a consultant. As Greg said, the other consultants who have been doing it for years are going to teach you. You're not going to get a chance to learn all the clinical skills again. And if you try to do it, at the end of the day, you're just going to be playing catch up your whole life. So
I think, unfortunately, we're really, really far behind in that. I mean, we don't have any clinical exposure in radiology training, because obviously we all do 3 years of diagnostics, and we don't have any clinical exposure. You really need to seek it out, as you say, go to A&E stuff, but it's just not part of our training scheme. And even in IR training, the only real clinical exposure that is not mandated, but is the clinics, and they're far and few between. I have a clinic, but very few people have a clinic. Out of 6 IRs, only 2 of us do clinics in my institution. So across the deanery, there's only probably a couple of clinics out of 40 odd IRs. We are miles behind the Americans in regard to setting up these clinical practices, which is exactly what you say we need, and I agree with you entirely.
I have a question for our UK colleagues. Do you guys have tumor boards for the trainees? Because when I was in diagnostic radiology, they actually emphasize on kind of the clinical picture as well, even in DR. Like, do you know the patient's history? Why are we reading the scan? What kind of surgeries have they done? And then when you sit at tumor board, you get to listen on why the clinical management are being made the way it is. So if you're stuck in DR, while, in the future pursuing IR, tumor boards is a phenomenal place to learn clinical management.
Yeah, we call them MDTs, or multidisciplinary team meetings, and it brings together the medics, the surgeons, the oncologists, and the radiologists. And I think you're absolutely right. That is the first point of your clinical exposure. If it can be called clinical exposure, it is clinical exposure on paper, but it's not physical clinical exposure. But
Correct.
yeah, that is, and that's certainly where we find cases, so to speak. So the more MDTs that IRs are involved with, the more cases you will generate. So as I said, in my institution, there's not many of us, so we managed to have a presence at vascular, HPB, and fistula, but we don't have presence at urology, for example. We don't have presence at lymphoma and all that sort of stuff. So your ability to kind of make cases, so to speak, is diminished by your inability to attend the MDTs. And I think you're absolutely right. That's the clinical in, so to speak.
And I'll just add, one last point there is that, there's a lot of people are caught up on this divide between different specialties and competition and, people taking away cases or other things. And, my own experience thus far, which is very, very early and, limited number of years, is even in those limited number of years, I've come to understand that the other specialties will respect you more if you know how to clinically manage your patients. No one is going to take away your cases. There's really enough to go around. And if you become clinically skilled and they can see that, they're only going to send you more patients. So it's a little bit of kind of backward thinking, or people just have it wrong, so to say, in that there's a divide and there's territory, and we need to grasp what ours is. That no, if you become collaborative and you show that you're able to take care of somebody and follow them up for however X number of years, they're only going to say that, hey, I like this person, I'm going to send them more patients at the end of the day. And that's been my exposure thus far in these very limited number of years. In my vascular surgery rotation, I worked my butt off in clinic, and I really showed interest, in procedures and in rounds. And our vascular surgeon said, hey, this guy really, enjoys this, but he's also serious about taking care of our patients. So we got more PAD coming through. We even started doing some, iliac work and, stuff that we should be getting, like renal stuff, or, arguably, other organ systems they sent to us, at the end of the day. So I think that's important.
Thank you.
Just to add something, because, I completely agree with everything that's been said so far. I don't want to put down completely our vascular training in the UK, because it's a bit unfair, I think, to say that. I think clinical training is an issue. I think, though, that every trainee who comes to radiology foundation training, which is training, okay. So after med school, and I'm just saying this to clarify for for medical students who are from the UK, or for people who are not in the UK, so they have an idea. So that you get clinical training, you just get it before radiology. So you do 2 years of clinical training as a foundation doctor, and then you join radiology. So it's not like you jump from medical school straight to radiology. So you're going to get some clinical training. Then the other thing is that we need to remember that in the UK, we have a structured IR training for the last 10 years. Okay, we have a subspecialty status for the last 10 years. We have you get a dual specialty as a DR and IR. Okay, and there are very few countries in the world that they have this. Apart from the US and maybe another 2 countries, if I'm not wrong. There are not many other countries, at least in Europe, they have this kind of thing. So we are pretty lucky in the UK that we have this structured approach to training. But of course, I completely agree that we need to do a bit more in terms of integrating more clinical training during those 3 years of IR fellowship. I think we can do better than there.
Oh, I think Greg is frozen. Greg? Okay. I mean, actually, oh, go on. Still there. Greg, you're laggy.
DTs, there's no doubt about that. We have to go to DTs for our training, make that all these things are in place. And it takes, as the American guys know very well, it takes a lot of effort, a lot of energy to convince the higher ups that things have to change, and it takes a while. But that's why we're here. That's why we're having all this discussion.
Yeah, I'm conscious we're almost running out of time. We may even overrun the 5 minutes. I think we have so many great inspirational women in IR role models here. I wanted to ask, how can we get more female trainees into IR? Because obviously the survey has highlighted that there is a discrepancy. Can I come to you, Apurva?
Firstly, I wasn't even aware that there was IR in India. There was this Backtable podcast where I've heard a women IR talking about practice of IR in India. Then I not only learned that there are IR practitioners in India, but also women. So when I reached out to her, I must say the interview was one of the best interviews I ever done in my life. Like, she mentioned about how there are only 8 women IRs, while there were 3 out of 351 the number of IRs in India, and that it's only 2%. And having having someone there, a woman there doing it, it's like an inspiration for us to like, okay, fine, I can do that too. Apart from it, in USA, we have this SIR RFS Women in IR. It's a committee where we take up multiple projects. So having a close set of people who are like you, who are working towards the same goal helps. That's something I would like to add. Yeah.
Thank you. Ornella, do you also mind sharing some of your thoughts on that?
Yeah, of course. I do believe that interventional radiology is a male-dominated subspecialty, we must say. In Greece as well, I think they're quite minimal. It's a quite small number of female interventional radiologists. I think that what we do need to inform women radiologists, like diagnostic radiologists, is the fact that the fetal dose exposure, because there are many false papers out there, false information that say that it's dangerous for women to be pregnant and have and work as in the ionizing radiation, So I think that's very important that we make that clear, and also maybe parental leave policies in each institute is also important. So I think if these small parts, we make these clear, then maybe more women will be interested in IR, because we are skillful as well. So I think it could work.
Oh, absolutely. We'll never disagree with that. Vicky, you've also had such a diverse training, and you've trained across different institutions. Any last lessons to share?
Yeah, well, from the women's perspective, I think we're very lucky in the UK that we do have fantastic, maternity pay, and leaving the scheme to go on maternity as a junior or as a consultant, it's no problem at all, basically. We're also very lucky that we can work part-time as a trainee or as a consultant. Having spent time in Canada, I did some IR work there, and the trainee who was training to be an IR had 2 children who are similar age to mine now, and it's hard work, and she was working full-time because she had no option. And we're so lucky in the UK that we have that, and it is very readily available. And I think we're lucky in IR because in the UK, you're essentially supernumerary as a trainee for most of your training. It's very easy to work part-time and to work around your needs. I take a couple of afternoons off a week to go and get the kids from school. And it's a very sort of family-friendly specialty, I think. And yeah, I think it's really flexible, which works great for me.
Thank you. Go on. Elin, were you?
Oh yeah, sure. I was gonna say something. I mean, I really wish we have the similar, maternity leave policy here in the US, but it really doesn't only apply to women here, it also applies to men. A lot of my fellows have kids, and their paternity leave is equally, limited. So it is just difficult being a full-fledged, like a full-time attending or trainees here. It's almost impossible to kind of adjust your training schedule in the United States. But I think one of the keys, and I agree with Aparna, is that having a female mentor and role model that you can look up to is huge. I mean, I went into IR because I had Marine as a mentor. I had Venkatesa in MD Anderson to look up to, and they really guided my path toward radiology and IR. But you know, there is a lot of misconception about the radiation safety, but I think we're almost gonna beyond that now. Like we spend so much time telling women, hey, IR is safe, right? Like you don't have to worry about your kids glowing in the dark when they come out. But now I think our message do need to evolve a little bit. You know, I think what we do is we do need more women in the field of IR in the leadership level, because now you're changing the message from like IR is safe to like IR is now an opportunity for you to break through the glass ceiling of medicine that we commonly have for women. So if you create kind of more exemplary women in the field of leadership, you will highlight that this is an opportunity for women. You will have more driven women to go pursue this field because it is an option that they know they have, that they can excel without limitations.
Thank you. That was so eloquently and very well said, Yulin. And I think so many powerful messages that transcend lots of areas in medicine that are not just applicable to our specialty. And unfortunately, I'm going to have to bring this session to a close. I would love to chat for hours more, but we've run out of time. So I just first of all want to thank everyone, all the panelists for chiming in, and thank you for all your insights. I want to thank obviously my co-chairs for making sure this is on to time and keeping me in check. And obviously all the audience members who are here, thank you so much for giving up your time. This is going to be a monthly session, so keep an eye on social media and the newsletters for updates. And please do fill out that feedback form, because we want to make this bigger and better every month for you. So finally, thank you to all the panelists, and have a good day if you're at work, or have a good rest if it's almost bedtime. Thank you very much, and take care, everyone.
Thank you.
Bye.
Thank you.
Thank you, everyone.